At doses of 1 to 3 milligrams, the molecule N-acetyl 5-methoxytryptamine, commonly known as melatonin, functions as a regulator of the circadian clock. Escalating the dosage to a pharmacological range of 20 to 60 milligrams alters its biological behavior. At these levels, the hormone's activity extends into complex anti-neoplastic pathways. Melatonin possesses an extraordinary safety profile with an LD50 of infinity. Reaching a lethal threshold is functionally impossible. This allows for massive doses as adjunctive treatment. Meta-analyses indicate that when used alongside conventional treatments, melatonin yields a 0.63 relative risk for 1-year mortality. In this high-dose context, melatonin functions as a multi-targeted anti-neoplastic agent and biological response modifier. To evaluate the clinical trial data that challenges standard oncology assumptions, we must first map how this molecule alters the physical and metabolic environment of a tumor. Rapidly proliferating cancer cells often rely on the Warburg effect, the use of inefficient anaerobic glycolysis for energy production, rather than standard cellular respiration. Melatonin intervenes in this metabolic process by targeting the top left section of this pathway map, the direct inhibition of the mitochondrial enzyme pyruvate dehydrogenase kinase. Inhibiting this enzyme forces the synthesis of acetyl-CoA from pyruvate. This chemical block forces the cancer cell to switch from anaerobic glycolysis back to conventional oxidative phosphorylation through the Krebs cycle. This metabolic shift has been documented to alter the profile of Ewing sarcoma and reduce glucose metabolism in prostate cancer cells, cutting off the tumor's preferred energy production method. Reversing the Warburg effect strips the tumor of its primary metabolic strategy, slowing its proliferative capacity and setting the stage for cell death. Beyond metabolic shifts, neoplastic cells must evade apoptosis, the body's process of programmed cell death, to form and maintain solid masses. As shown on the right, melatonin overcomes this evasion via the MT1 receptor, resuming self-destruction. It initiates massive upregulation of pro-apoptotic mediators, p53, BAC/BAC, APAF1, and caspases, while suppressing anti-apoptotic survival factors like BCL2 and the AKT-MDM2 axis. By activating death receptors and shutting down survival factors at the same time, melatonin rewires the tumor cell to self-destruct. A solid tumor cannot grow beyond a certain size or metastasize to other organs without recruiting a dedicated vascular blood supply. The bottom left of the pathway diagram illustrates melatonin's anti-angiogenic mechanism, the direct inhibition of hypoxia-induced factor 1 alpha. Suppressing HIF-1 alpha prevents the tumor from expressing vascular endothelial growth factor, or VEG, which is the primary signal for recruiting new blood vessels. This prevents endothelial cell tube formation. As shown in the bottom right panel, this cascade also alters the PI3K and MAPK signaling pathways to block the cancer cells from migrating. By blocking VEG and disabling migration pathways, the tumor remains trapped in a localized, starved state. To survive in the host environment, advanced malignancies must also actively suppress the patient's immune surveillance. The top center panel details how melatonin acts as a biological response modifier. It downregulates regulatory T cells and FOXP3, which shield cancers from immune detection. With the shield lowered, it stimulates CD4+ T cells, Th1, and natural killer cells to mount an attack. Melatonin also functions independently as a natural anti-estrogen and aromatase inhibitor, restricting the growth of hormone-sensitive malignancies in the breast and prostate. The hormone attacks the tumor's metabolism and blood supply, while systematically dismantling its defenses and recruiting the host's innate immune system. Mapping these molecular pathways provides the theoretical framework for how melatonin functions, but human clinical trials provide the evidence of its efficacy. The Seeley meta-analysis systematically reviewed 21 randomized controlled trials evaluating melatonin as an adjuvant therapy in solid tumors. The pooled data across these trials yields a definitive endpoint. Patients receiving adjuvant melatonin experienced a relative risk for 1-year mortality of 0.63. Research led by Dr. Paolo Lassoni demonstrated that melatonin amplifies the effects of primary agents like interleukin-2. This synergy allows for lower effective doses of IL-2 that avoid the severe side effects typically associated with that treatment. In separate trials, patients with metastatic breast cancer who were no longer responding to tamoxifen achieved partial tumor regression after adding pharmacological melatonin to their protocol. This 37% reduction in mortality risk positions melatonin as a high-efficacy adjunctive treatment, supported by the same statistical standards applied to conventional oncology. A primary challenge in oncology is delivering a high enough dose to kill the tumor without causing treatment-limiting toxicity in the patient. Melatonin displays a split behavior. While it exerts aggressive cytotoxic effects on tumors, it simultaneously acts as a cytoprotectant for healthy tissues. Patients using melatonin alongside chemotherapy show significantly lower rates of side effects, including myelosuppression, drops in platelet counts, severe fatigue, and nerve damage. With an LD50 of infinity, melatonin is an accessible, low-cost adjunct that protects healthy tissue while it amplifies tumor remission rates. High-dose melatonin acts as a pleiotropic metabolic and immunological modulator. By targeting the fundamental biological processes of a tumor, it increases the overall efficacy and tolerability of standard cancer therapies.